Mr. President, dignitaries on and off the dais, respected international participants and faculty, my brothers and sisters in the care of vitreoretinal diseases, ladies and gentlemen. I am immensely proud, privileged and honored to have been given this award today. In my two previous Lifetime Achievement Awards given by the Tamil Nadu Association and the All India Society, I realized that they were also recognizing the work that I had done for the organization. This award, on the other hand, is special because it is given as a recognition by the peers in the vitreoretinal field, recognizing my work in that field. I thank you once again for the honor. A few days ago, President Giridhar came to my house to discuss the modalities of this award. And he said, "Isn't it possible for you to come and receive it personally?" But considering my health condition, I told him that as much as I would like to do so, it was not possible. And he said, "Okay, give me a presentation which outlines how you started and what you went through to reach this level." And then I thought of what Confucius had said, "Study the past if you would define the future." And so my talk today is entitled Kal Aaj Aur Kal. A little bit of yesterday, today and a little look at tomorrow. If Lalit is in this audience, I am sure he will be tickled pink knowing the amount of Hindi that I know. I joined MS Ophthalmology in 1972 at Manipal under Professor P.N. Srinivasa Rao. I was his first student and he had just returned from a Commonwealth Retina Fellowship with Dr. Faison in Moorfields, London. So it was not surprising that my thesis topic was related to retina, and it was fascia lata as a buckling material in retinal detachment surgery. For the next 3 years, I worked closely with him on all retinal cases. In fact, for every retinal detachment surgery, I started the case 1 hour earlier to remove the fascia lata from the patient. And in fact, those patients complain more of the pain in their leg than in their eye for the following week. At the end of my MS, I got an opportunity to get an international retina fellowship at the Eye India Hospital in Melbourne under Professor G.W. Kroc, the inventor of the first spectacle indirect ophthalmoscope, and this incredible instrument called the Comedo, a combined operating magnifier and miniature indirect ophthalmoscope. If you pulled these two levers out, it was an indirect ophthalmoscope, and if you push them in, it was a 2.5 magnifier. I therefore dedicate this award to the memory of both of them. This was the coherent 800 series laser that we used, the first one to come to Australia in 1976. These were very demanding machines. They required a lot of power and also a lot of cooling water. This particular machine had what was called a safety filter. It was a piece of paper which was stuck and moved up and down during each press of the foot switch. Over a period of time, the paper tore and you would suddenly get the blue-green light of the laser coming back at you through the eyepiece. In 1978, I came back after my fellowship and joined Shankara Nethralaya at 18 College Road in this building as probably one of the first 10 employees of that organization. This coherent laser, also an 800 series, was placed behind this window, and next to that window was a manhole where there was a sump, and this cooling water was taken from here to this tank here and then brought down and pumped at 30 psi through the tube. We then realized that the inlet temperature and the outlet temperature was different or more by about 2 degrees, and in summer this became very difficult because the inlet temperature itself was close to 40 degrees. So in the early morning on days of laser, we threw in 3 or 4 blocks of huge blocks of ice into this sump and brought down the temperature to around less than 20 degrees, and so this recycled water went on and on. In 1979, we did the first laser on a human being in any medical specialty. This is Dr. Badrinath, and this is me having the honor of doing this first laser on a very VIP patient who was waiting for a PRP to be done rather urgently. After I left Shankara Nethralaya and started the Eye Research Foundation in 84, around 1990, we got the first tunable dye laser into India, and we were told by the manufacturers that this was the first laser east of the Suez Canal. This was a 9-watt argon green laser into which was pumped rhodamine 6G dye, and the laser came out with different colors. With this laser, we did a study to see the effect of different colors of light, and we found that the blue light 488 was actually toxic to the eye, and unlike what the DRS study said, it did produce a field defect if checked with a threshold perimeter and not the Goldman perimeter. You could also tune to get a 513 green light in which there was less field loss, but those days subsequently they made a green laser of 513 where it was green was separated from the blue using a special filter. We could also tune to a yellow 577 nanometers which had no field loss, it had no pain, and was ideal for this particular pan-retinal photocoagulation. There was also 595 which caused a little pain but was never very popular, and finally there was a 620 red which caused severe pain. It didn't produce any field loss, but sometimes if we wanted to do a pan-retinal photocoagulation, we had to give a retrobulbar injection, so it was not very popular. We presented these findings in early 1990 at the All India Conference, and the chairman of that particular session asked me, so what do you think is the future of these lasers? And I said, first of all, it will not be a tube laser, it will have to be a diode laser. At that time there were only red diodes, and I said the future as I see it would be a yellow diode of 577 nanometers. And this was because of the high absorption by oxyhemoglobin, less thermal spread, negligible absorption by the macula xanthophyll, better transmission through opacities, better lesion visibility, because in those days the aiming beam was an attenuated part of the treatment beam. So it was the aiming beam itself was yellow, and you almost lit up the inside of the eye like a sodium vapor lamp, and less power was required and because of less scattering, and there was no field loss. Today, nearly 25 years after my prediction, a yellow dye laser is available and is probably the laser of choice. During my career, I had fiddled around with a few innovations, some technical and others not technical. In those days, when fluorescein angiography started, people used to just roll up the film and give it to the patient. The patient didn't know what to do with it, the doctors didn't know what to do with it. We made strips of this and stored these pictures with us, but gave the patient a positive print on a lithe paper, which we soon realized needed something like an X-ray lobby to view. So we changed that and started giving it on bromide paper. But in both cases, we always gave a printed report with it. Today, in the digital age, we find that you can include a color photograph, the angio, and a printed report all on the same sheet. But even then, when we started giving these reports, we had our own software to print these reports. We had a database of nearly 2000 odd reports, pre-formatted reports, which had a code number, and we had a program. Once we saw the picture, patient's picture here, then we entered whether it was a right eye run first or a left eye run first, and then we just decided whether it was a BGR. These were arranged alphabetically, and if it was a BGR, we just picked up the code relevant to that and entered the code, and the whole report would get typed in there. We had three different types: the first eye, the other eye, and the impression. So you had to fill these three, and the whole thing would get automated and typed properly. Photodynamic therapy, I realized, is a photochemical process like photosynthesis. It does not require a laser, it does not require a strong light, it does not require the light to be focused, it does not require the light to fall exactly on the lesion, and therefore I replaced that laser with a non-laser red light, 325 milliwatts per square centimeter for 120 seconds. I at the moment have a patent pending on this equipment, and I am working with these people who have developed the equipment and the control panel. I use only 60% of the 450 milliwatts power that this light emits, and I set up to, this is up to 5 minutes, but I use only 2 minutes or 120 seconds of light, and this is done lying down attached to operating microscope like system, and the light falls on the patient's eye. Just remember that there is no speculum, no nothing on the eye. The patient just has to concentrate on this. He can blink, in fact he has to blink so that the eye does not get dry. An absolutely painless process. Compared to PDT done with the standard protocol, we have got results identical, where they are stabilized for 37.5%, improved in 37.5%, making 75%, 25% got worse, and the mean retinal thickness also decreased by 37.5%. So what are the advantages of the 685, 687 nanometer red light? It is much cheaper than the laser, no need to measure GLD, and since the light is reacting with Visudyne, which is sitting in the new vessel, we fill the eye with the red light and we allow the lesion to find the light. There is no chance of a choroidal rip because this is not a laser, and we have got comparable results. Futurology has been one of my favorite pastimes, and this started because in the year 1988 the Tamil Nadu Ophthalmic Society had asked me to give a talk of ophthalmology in the year 2000. Those were pre-internet, no Google, no Wikipedia days, and it was a real challenge to do that. This slide is the first slide of what was the first electronic audio visual presentation in any medical conference in this country. Presentation software had not been invented yet. PowerPoint was bought or launched by Microsoft only 3 years after that. And so I talked about ophthalmology in the year 2000, and at that meeting I told that audience that remember, one day all presentations will be electronic. In the year 2000 I was asked to give another talk on ophthalmology in the year 2020, and therefore I made another prediction. I am very glad to tell you that over the years these predictions have almost become accurate to about 80%. So, very quick look at what the future holds. Nanotechnology will become play a major role. It will deliver drugs which are dose specific and site specific. Nanobots will be used to travel within blood vessels inside the eye and go to any area that needs to be treated locally. Biotechnology will involve artificial retina, bionic eyes, synthetic cornea, and genetic engineering. Stem cells will be used for storing for future use, for regenerating any tissue, and can be used also for 3D printing. Printing itself, if you use synthetic materials, you can customize spectacles and contact lenses, and if you use stem cells, you can make any ocular tissue. And finally, robotics. I recently had my cataract done by robotic surgery. It took all of 1 minute and 20 seconds. All I heard the surgeon say was approve, 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 and it made an incision, made a rhexis, softened the lens, and divided into small pieces. These are the advantages of robotics, including telesurgery. Just imagine, not the next time the VRSI comes to Bhubaneswar, but the time after that probably, you will have a robot sitting in Bhubaneswar and one of our international guests operating it from their own hometown and demonstrating live surgery. A future eye department will therefore have an ophthalmologist, a computer specialist, a genetic specialist, a communications expert, neurodiagnostician, and probably a neurosurgeon as well. So, can all the blind eventually see? Undoubtedly the answer is yes, but the question is when. Trying to make an astrological prediction, I think 2020 is too soon. More likely it will be closer to 2040. On that day, the deaf will hear the words of a book, and out of their gloom and darkness, the eyes of the blind will see. From the Bible. And then by the year 2045, my birth centenary year, you will find in the dictionary the word blind was defined as a condition prevalent up to the early 21st century, unable to see, lacking sight, sightless or blind, nearly eradicated in the mid 21st century by technological advances. Once again, I remind you that as I said with the yellow diode and as I said with the electronic audio visual, again I am telling you in 2045 most of you will be around to see this happening. You tell your children and your grandchildren that 27 years ago a chap called Babu Rajendran told us that this will happen. I thank you very much for this great honor.